Right, good afternoon, everyone. Thank you again for joining us. Sorry we're a couple of minutes late now. I was having technical issues in the background. And welcome to everybody who's also joining us on Facebook. If you are joining us on Facebook, you can still ask questions. Use the comment function, and we have people who are monitoring the various posts and will feed those questions back to us. So yeah, hopefully you won't feel too left out if you're watching on Facebook. So welcome to the webinar, everybody. Today we are here to talk about treatment-free remission and also dose reduction for chronic myeloid leukemia, or CML. I think we'll probably refer to treatment-free remission from now on as TFR, but obviously that's the same thing, and we'll shorten chronic myeloid leukemia to CML for speed. As I said before, you can ask questions using the chat function. We won't be allowing anybody to ask questions verbally or put their camera on or anything like that. We've just got too many people to manage that with. I see we've got one question already, so thank you to that person. So to make a start then, so I am Charlotte. I'm the Patient Advocacy Manager here at Leukemia Care, and I'll be chairing today's discussion. And I'm pleased to be joined by three panelists here. So we've got Professor Stephen O'Brien from Newcastle University Hospitals. We've got Nigel, who's a CML patient, and David, who's also a CML patient. And I'll ask them to introduce themselves individually in a moment. Thank you all for your time. So Stephen, would you mind kicking us off with just introducing yourself, but also giving us a bit of an introduction to today's topic?
Sure. Yeah, thanks very much, Charlotte. So I'm Steve O'Brien. I'm a haematologist, an academic haematologist at Newcastle University. I have two jobs these days. I look after patients with leukemia and lymphoma, specialise in chronic myeloid leukemia at Newcastle. And my second job, it's about half my job, is I chair a NICE technology appraisal committee, looking at new medicines and their introduction into the health service. And there's lots of interesting new things in leukemia, not so much in CML these days. I think we've got some fantastic drugs already. But that's me. Charlotte, do you want Nigel and David to say hello before I yabber on a little bit? Or
no, if you want to do the introduction, then I think we'll ask them to introduce themselves individually afterwards.
Okay, so Charlotte had asked me to give a few words, maybe no more than 4 or 5 minutes, on what exactly we're talking about today. You'll be delighted to know I have 0 PowerPoint slides. I think having to sit through PowerPoint on Zoom is just marginally better than having your toenails extracted with pliers. So no PowerPoint from me. I think it's more important to have a conversation, and no pliers for that matter either. So 4 things to say to start with. We're going to be talking about treatment-free remission. So firstly, what is treatment-free remission? Secondly, is it the same as being cured of your leukemia? Thirdly, if treatment-free or going treatment-free, stopping your treatment is an option, who's it an option for? When should it be considered? And fourthly, if you've chosen to go down that path, what's the practicalities? How do you go about it? How are you monitored, etc.? So firstly, number 1 and 2 are related. Treatment-free remission and cure are related in medical terms. If you have an infection and you go on antibiotics for 2 weeks, when you stop those antibiotics, hopefully the infection has gone away for good and never comes back. Sometimes it might come back. But being free of the disease and on no treatment for a prolonged period of time, I guess in most people's book is the same as cure. So TFR, treatment-free remission, is a fairly straightforward idea. And in CML, it means for people who've been on treatment, whatever treatment that might be, for usually a number of years, there are a proportion, and we can talk about the figures as we go through, there are a proportion who can stop treatment and in whom the leukemia doesn't come back. So if you have stopped treatment and a year later there is no detectable leukemia by PCR, and again, We can talk about what PCR means and what levels are important, that kind of thing. But if you've got no detectable disease a year after, you are in a treatment-free remission. I think after 1 year in treatment-free remission, I wouldn't be completely confident that somebody was cured. But if after 3, 4, 5 years, certainly 10 years, then if there's no detectable disease and you've been off treatment for 10 years, and I've got a couple of patients that I look after in that position, then I really think those folk are probably cured. You can have a late recurrence of your condition once you've stopped treatment, and we can talk about that a little bit more. But I think the notion of cure really relates to how long you've been off treatment for and how long you've been in remission for. And traditionally, historically, in cancer terms and in haematology circles, it's been 5 years. So if you wanted some kind of operational definition, not perfect, but a reasonable one, if you have had a treatment-free remission for at least 5 years, chances are your CML has probably gone away for good. So that's the first two ideas which are kind of linked in. The third thing is when you might consider going treatment-free, stopping your treatment. And again, there's lots of studies, lots of data that we could talk about in more detail in our conversation. But broadly speaking, to consider stopping treatment, you need to have been on it for a while. And by a while, I think most of the evidence would suggest at least 3 years. And if you've been on it for 3 years with maybe 2 years worth of very low level or no detectable disease, I think that's probably the earliest that's reasonable to consider stopping treatment. Even that's fairly early, because a lot of the studies show that the success of stopping relates to a couple of pretty obvious things, really. One is how long you've been on treatment for. So if you've been on treatment for 5 years, rather than 3, you're more likely to succeed when you stop. And also the depth of your response. So if you've had a very deep response, no detectable disease for a year, it's more likely when you stop that the disease will come back than if you've been in that situation for 3 years. So as a rule of thumb, and we can talk about it, I tend to discourage my patients from trying to stop unless they've been on treatment for at least 3 years, preferably more, and have had a very deep molecular response or no detectable disease for at least 2 years. And there's a bit of a difference, and again, we can talk about it in our conversation, between people who have no detectable disease and who've got, say, a major molecular response. And we can talk about how that's defined. So we've talked about what's a TFR? Is it the same as cure? Who should look at it? And the fourth thing, just by way of introduction, I'd cover is, if you go for it, how should you do it? So let's say, you know, in discussion with your docs, you think that stopping treatment or reducing treatment, and again, we can talk about the difference between reducing and stopping. You think that's a good idea for you. What do you do? Well, you need monitoring more carefully. So traditionally, I suspect most folk on this call with CML get a PCR test once every 3 months approximately. The guidance, it varies a little bit from different sources, but broadly speaking, it's recommended to have a monthly test for the first 6 months and then maybe go back to 3 monthly, although there's some theoretical modeling. There's a couple of publications out there saying it could be all right to have a 2 monthly test for the first 6 months and then go to 3 monthly. But if your disease is going to come back, it tends to do so in the first 6 months. So that's the time when you need to have probably more frequent testing. And I think probably monthly is a good idea, because if it's going up quickly again, you'd probably want to reconsider starting treatment. And again, in our conversation, we've got an hour or so, an hour and a quarter to chat. I'm very happy to discuss the details of that, the practicalities. And of course, at the moment with COVID and everything, we're all meant to be avoiding hospitals. And, you know, if you want to stop now in the midst of COVID, and I've had this conversation with patients, and again, happy to have it with you, is it a good time to be stopping? Or, you know, because you're going to have to either get someone to come to your house and get some blood off you, or go to the GP and mix with other people, or go to the hospital and likewise. Is that a good thing to be doing at the moment when COVID is still so rife? So just for general observations from me, Charlotte, to start with, no PowerPoint, and happy to explore any and all of those things in a further conversation. So back to you, Charlotte.
Perfect. Thank you, Steve, for setting the scene nicely. And I really liked your analogy with antibiotics. I think that sort of explains the rationale, or how similar the rationales are there. Okay, so before we start diving into some of those topics that Steve's brought up there, I wanted to bring in our patients today. So we'll start with Nigel. Nigel, thank you for joining us. Could you introduce yourself and who you are and personal details, and then maybe explain your relationship to this specific topic of TFR and dose reduction, and what your experience of these things are?
Sure, no problem. Nigel Deekes, CML patient for 10 years this year. Doing well, I'm on imatinib. My experience at TFR, I went on to the Destiny trial about 6 years ago. It had been about 3.5, 4 years into treatment at the time. The Destiny trial was a trial where you reduced the TKI you took for 12 months, having a monthly PCR test during that time. And then at the end of the 12 months, presuming you were still under MMR, which is 0.1%, then treatment stopped. I found my numbers quite strange, really. And interested to know from Steve in a bit whether this is commonplace, but certainly for the first 3 or 4 months of going on to half dose, my numbers actually fell. And I got some of my lowest numbers ever, because I was at about MR4 when I started, rather than lower than that. Then gradually over the next 5 or 6 months, I saw my numbers starting to rise, to the point at month 12, I was actually just over 0.1%. So I had a retest done and I came in just under 0.1%, and therefore attempted TFR. It was pretty obvious I was going to fail because my numbers were on the rise. Did 1 month off and then came back onto imatinib, and I've been back on imatinib for the last 5 years. Numbers fell rapidly on recommencing treatment, which again, Steve will pass comment on this, but I think for most people, if not almost everybody, their numbers do drop again rapidly and they achieve a deep response. And for about the last 3 years or so, I've been bumping along at MR 4.5, which is just about undetectable. I've only ever had one undetectable result, and generally I come back with 2 or 3 leukemic cells. So I've been at that point now for, as I say, about 4.5 years. I have my 10th anniversary in September of this year, at which point we should hopefully be COVID free, or at least safe enough to get up to the hospital on a regular basis, to enable me to perhaps have another go at TFR. And as Steve alluded to a moment ago, now maybe not quite the right time to do it. And as I say, I think a 10-year point is quite fitting. Whether it will work for me or not, I don't know. I'm quite philosophical about it, to be honest with you, because I'm very well on treatment and I'm one of the lucky ones that I always have been. And, you know, Steve talks about cures, etc. I sort of view myself at an MR5 as sort of having an effective cure, in effect. I want to stop treatment really for the reason that, you know, I was diagnosed at 45. If I live to be 85, which, you know, hopefully is a reasonable chance I'll do that, 40 years on treatment is a long time. And I think it would be nice to come off at some point, because you don't know, potentially there'll be an issue in 20, 30, 40 years. There doesn't seem as though there will be. I mean, imatinib's been around for 20 odd years now. So that's my background. Didn't work for me. Will have a go second time. Personally, I think second time I stand a better chance, because I've had a depth of response for significantly longer. And every year that goes by, I think your chances of success increase, I believe, by something like 6 or 7%. So that's me and my background, basically. Yeah. Back to you, Charlotte.
Thanks, Nigel. That's a great introduction. Thank you for taking us through the various stages there of your TFR journey so far. Before we go to David, I wondered, Steve, if you could just chip in with a bit of an explanation about some of the terminology that Nigel used around MMR and depth of response. And how is that measured in CML, and what do those terms mean, just in case we've got any newly diagnosed people with us?
Yeah, I suspect there's a range of people on the call, from experts who could probably give this talk or this session,
yes,
through to people who maybe have never joined one of these things before. So apologies to the experts, but I'm talking to someone who might be a newbie in this area and has little experience of these things, or maybe the terminology. So experts, you can do something else for 2 minutes. So depth of response is really measured by something called PCR. That stands for polymerase chain reaction. It's a bit of a jargony term, but it's a laboratory technique which can pick up very low levels of DNA and RNA, basically. So you can tailor it to pick up tiny amounts of leukemia, because we know very specifically in CML what the faulty RNA genes are, if you like. So depending on what technique you use, you can pick up sort of 1 in a million to maybe 1 in 100,000 cells. So it's a very sensitive way of doing it. And for years now, that's been the kind of standard of measuring how well you're responding. You might wonder, why don't we look at the blood count? Well, we do, but it's very easy to get a normal blood count in CML. And it doesn't really, it's not very sophisticated. It doesn't tell you the level of response that you're getting. So major molecular response, or MMR, is a ratio of BCR-ABL, which is the leukemia gene defect, against ABL, which is the normal one, of less than 0.1%. And obviously, no detectable disease means 0. There's debate about that as well, because it depends how sensitive the test is on that day. But MMR is quite a common thing to talk about in this situation, because one of the studies we might look at, one of the thresholds for stopping or reducing, is not necessarily 0, but being an MMR, major molecular response, less than 0.1%. So Charlotte, I think that was the main bit of jargon to explain there, but happy to cover anything else if you wish.
No, that's perfect. Thank you. I think that just helps any of the new people, like you said, who may not be familiar with some of the terms we're using. And please do put in the chat if there's anything else we say that you don't understand. We can always stop and discuss them a bit more. So to bring in our final panelist, David, who's been waiting very patiently, thank you for that. David, you just want to introduce yourself and your relationship to this topic as well for me.
Sure. So I was diagnosed back at the kind of back end of 2012. I think I wasn't caught particularly early. I think I had sort of 10% blast in blood. BCR-ABL was over 300%. So quite high numbers to start with. And I was on the SPIRIT-2 trial, which was imatinib versus dasatinib. And I was on the imatinib arm of that trial to begin with. It actually caused me quite a lot of problems, a lot of bone pain, and it didn't actually work that well for me. So I was switched to dasatinib after about 3 months. So at that point, kind of dose reduction, TFR, absolutely not on my schedule whatsoever. So I kind of just took the 100 milligrams of dasatinib for what looks like about sort of 5 years. And my blood counts came down nicely, and everything did really well. And I got myself into a kind of MR4 position with my results. So doing really well on 100 milligrams, found myself quite fatigued. Had always found that as the kind of major side effect I got. A bit of kind of muscle sort of call it musculoskeletal pain, but not terrifically bad. But fatigue meant I couldn't work full time, which was sort of obviously impacting life in general. So that's what I kind of thought about. Could I stop, or what else could I do? Stopping felt a little bit scary at the time. And this is a question for Steve, I guess, as well. I don't know if there's a relation to somebody who is diagnosed sort of early stage or late stage, and whether that impacts their ability to try TFR later on. But I felt that if I could wean myself down from 100 milligrams, would that maybe be a less risky thing for me to do to help improve my kind of quality of life? So with my doctor at Bart's, we decided that we'd take a pretty cautious approach and try to reduce in small steps over a longer period of time. Reasons for that were primarily driven by me, which was I had just had some small children who had a pretty difficult entrance to the world and quite a few life changes, and I didn't really want to rock the boat. So wanted to sort of take small, careful steps. So we went down to sort of 70 milligrams of dasatinib first, and then would wait to see that MR4 response was maintained. And after, I think 6 months later it was, so we dropped down to 50, and again held that for another 6 months, and then dropped down to just 20 milligrams. And that's where I remain today. So I've been 2 years on 20 milligrams. I've got from that MR sort of 4 down to MR 4.5 quite typically. My second to last PCR was actually undetectable, which was the first one I've ever had. And my last one just this week, there wasn't enough RNA in the sample, so I don't know. But it's going well, and I certainly feel much better taking the low dose. But that was my kind of plan, was to find what's my lowest tolerable dose that keeps me in a good state. And then I figured if I stay in that low state for longer, that if I do decide to stop eventually, that probably gives me a better chance of succeeding. And a bit like Nigel said, I was diagnosed at 33. I don't fancy taking drugs for 50 years, or maybe more, maybe less. So at some point in the future, when, maybe not this year for not just COVID reasons, but, maybe just as my kids get a bit older and life is a bit more settled, that's something I might try.
Great, thank you, David, for explaining that. And I think I wanted to pick up the first question from what you said there, one for Steve, actually. So we've got 2 people here who have reduced the amount of drug they take in different ways. Do you see dose reduction and treatment-free remission as 2 similar concepts, or are they 2 sort of entirely different strategies in your opinion? I mean, we wanted to talk about TFR today, and we thought we can't talk about TFR without talking about dose reduction as another option, but do you see them as sort of one and the same, or?
I would distinguish them, broadly speaking. So I quite commonly change the dose and reduce the dose of TKIs for my patients. And it's kind of along the lines that David has explained. Quite often not that often, a minority of people struggle with any given tyrosine kinase inhibitor they've been put on. Imatinib, I think most people are fine on, and Nigel is a testament to that experience, I think. But some people do struggle with it. Other drugs have got problems. So dasatinib, for example, that David is taking, it can cause pleural effusions, a collection of water effectively around a lung. That's quite clearly related to dose. And sometimes in people who've done brilliantly well on their PCR on dasatinib on full dose, if they get a pleural effusion, for example, I might well suggest that they reduce the dose and maybe go as low as David is on at 20 once a day, which is a fifth of the normal dose, because then you can get a great disease response, but avoid the side effects. So I equate in my practice, I think, dose reduction to normally be something to be doing when you're trying to manage side effects. Now, having said that, looking at treatment-free remission, that there's 2 broad ways that people have approached this. I'm just looking up, I totted up the total number of patients and studies that have looked at stopping or dose reducing, and there are, for people's interest, there are 21 published studies which include 2,974 patients as of 2020. So just under 3,000 patients have been involved in studies of trying to secure a treatment-free remission. Most of those have been stopping something. So you get to an excellent response and you completely stop what you're taking. And others of those, and there's one UK study particularly called Destiny, but there are others coming along now, where instead of stopping, you dose reduce for a year, and then you stop and see what happens. And curiously, and people can't really explain it, the dose reduction and then stop approach seems, in one study anyway, to give a higher success rate than completely stopping. So to answer your question, dose reduction more commonly in managing side effects and toxicities. Stopping completely is the standard way of going for TFR, but there is a newer and as yet not as well established method of dose reduction aiming towards stopping. So I hope that makes that clear, Charlotte.
It does, thank you. And David, I think that matches up to your experience, as in you didn't start reducing your dose with the aim of TFR. It's something you've come to later. Did I understand that correctly?
Yeah, I reduced the dose for getting managed side effects, and kind of like Nigel said, just, you know, the drugs work on your liver and kidneys or whatever else, and just to reduce general toxicity. But knowing that in the back pocket, that if I wanted to stop in the future, it might be a path to that.
Great, thank you. We've had loads of questions coming in. I'm trying to keep up with them all, but we will try to get through all of them. So please keep typing them in, everybody. I think my first question, again to Steve, but also I wanted to pose this to everyone else afterwards. There was a question in the chat box about whether someone asking if they were ready to stop, and Steve, you said 3 years with 2 years of deep remission is when you'd think about it. At what point should TFR even start to be discussed? Is diagnosis, would you discuss at diagnosis the possibility in the future of this happening, or is it very much something you tend to have a conversation with patients about later down the line?
I'm going to answer it in a slightly strange way, Charlotte. I'm going to give you an example of how this has actually happened in the last couple of months. And it's partly COVID related. You know, we are really being told not to bring patients to the hospital. But if you've got a new diagnosis of leukemia, I don't think it's great to have a phone chat with somebody to have all that discussed with. So I make exceptions in those situations, and we sit across the room with masks on and all that paraphernalia. But I do bring people into the hospital for that initial chat, because, you know, I think that's what I'd want if I just got diagnosed with cancer, is to see somebody face to face. So I don't necessarily raise TFR at the very first meeting, because I think people are often shocked and just coming to terms with this diagnosis. Often it's picked up incidentally. So people were not expecting CML at all. They maybe felt okay and were having a blood count for another reason. So at meeting one, I think it's just to actually to reassure people mostly, because the treatment is so good for CML these days that you can broadly say that, you know, as Nigel and David are planning for their old age pensions, etc., that's a very realistic proposition, thank goodness, due to, you know, modern technology. Yeah. So I think the first meeting is explanation, reassurance. Generally speaking, second meeting, again, I'll try and do it face to face. Would be, you know, explaining how we manage, what PCR means, all of those numbers, just getting used to it. And then as people settle down, I think, and get used to the fact they're not going to die straight away from this, and the treatment is very good, then I will map out what the next 3 to 5 years might look like at a third consultation. And of course that varies. Some people have read up on it straight away and they're all over it on the first one. Some people don't want to have the conversation, but that's kind of how I do it, is, you know, settle down, get used to it, get used to some of the jargon, think about the long term. And critically, I think that gives people their lives back. You know, if you get told you've got leukemia, you think, I'm going to die straight away, that's the end. But that's not the case here. And I think once people get their heads around that, and the fact that there is a potential that you could be even cured of this condition, minority, but it could be, but at the least you're going to most likely have a normal life expectancy. I think that's how the conversation tends to go in my experience.
And Nigel, you're nodding along there. Is that, from a patient perspective, does that seem like a reasonable way of going about things, thinking across the whole of your I don't want to say journey so far?
Yeah, I think it is. I think, as you say, at diagnosis to discuss stopping treatment is, it's probably nice to mention, you know, potentially mention that it's out there in the future, but it comes as such a shock. I mean, Steve said a lot of people have picked up without expecting it. I certainly was. I thought I got a detached retina. Went in to see my doctor, came out with the diagnosis of leukemia. So, you know, So yeah, I agree. I think there's the right time, having that opportunity to discuss it. Some patients, again, as was mentioned, want to know everything, and other people really don't. And part of the Facebook group, and always does genuinely still surprise me. We'll have people join us sometimes who've been on treatment for 3, 4, 5, 6 years, and they don't know what MMR is, and they don't know what 0.1 or whatever the case may be, because they're quite happy to go along to the doctor, and the doctor said, "Yep, you're fine, you're doing well," and that's fine as well. Everyone's own situation, what they want to know, differs. But I think having that reassurance that CML is such a treatable disease these days is a great comfort from the point of diagnosis, and dare I say, a bit of a surprise as well. I made a point of not Googling things, because my experience of most things in life are people only go on the internet to say bad things. They don't go on and put on, "Hey, I'm wonderfully well." So I decided not to. But then as I started hearing about this wonder drug, Haematologist, bear in mind it's 10 years ago and things have moved on with other treatments, I did start to Google, because it almost seemed unreal that I was going to do so well on it, frankly. So yeah, I concur with that, really.
Great. David, do you feel the same, I guess, is my question?
Yeah, I would have been certainly the reader for my doctor. I'd be the one coming in with a study and saying, "Can I do this?" or "What does this mean?" So I would consume as much as I could to try to learn about as much as I could about CML in the early days. So I'd like to think I was a pretty informed patient, and so I read about TFR, and it was something that kind of, as I said, I discounted as something that I would consider for years. So
I guess
I think one thing I would just add here is my experience of people who are members of Facebook groups or CML support, etc., are generally knowledgeable patients, because they wouldn't be part of the group if they didn't want to know about it. I know it's stating the obvious, but you don't necessarily think about it. If you're in these groups, you generally are going to be reasonably well informed.
Yeah, that's definitely true in my experience.
Charlotte, can I just chip in a thought at this stage, if I may?
Of course.
I don't want folk on this call to think that they have to go for treatment-free remission. Over the years now, I've been asked the question, "What would you do, doc, in my situation?" And Nigel, I think, is quite a good example of that. I mean, he expressed the reasoning for him wanting to stop. He's been on drug for 10 years. I think, Nigel, you've not had too much in terms of side effects. And if you look at most things in medicine, if you had high blood pressure, if you had diabetes, if you had wonky lipid levels, cholesterol levels, you'd probably be on treatment for the rest of your life. And if that's a pill a day that causes 0 side effects, and I guess with my nice hat on, doesn't cost bajillions of pounds, then, why not take it till the day you die? It's like taking a vitamin pill in a way. If your quality of life is excellent and your quantity of life is normal, then taking a pill every day, regardless of what your PCR is, maybe that's fine for you. There's lots of debates, and you can maybe imagine the American stand on this. I hope we haven't got any Americans on the call. I'm not meaning to be insulting, but a US perspective, I find particularly is, we must absolutely hammer this PCR level down at all costs, because treatment-free remission is absolutely where we have to be, because we need to cure this disease and get everyone off treatment. Now that's, it's a point of view. It's a point of view I don't happen to agree with, for the reasons I've said. So if you are comfortable trying to stop treatment and getting a TFR, then great. I think your docs can and should help you. But I don't think you should feel obliged to. And I think chances are you're going to have a normal length of life and probably a normal quality of life on treatment if you're not having problems with it so far. So I thought I'd just chip in with that thought. I don't want everyone to feel they have to get a TFR.
Yeah. Can I just interject there, because I know I've discussed this with Steve previously. I'm with you 100%. I mean, I am, as I said at the start, I'm one of the lucky ones, and I know that, and I have a good quality of life. I'm not actually that bothered whether I stop treatment or I don't, for the reason you just said a moment ago. Mine's purely that 40, 45 year aspect. It's honestly the only reason why, because you don't know. There isn't the data there. Taking a pill for the rest of my life, I take a glucosamine sulfate every day for my knees. because I play squash. It's not the same thing, but I don't have a problem with taking the pill. So I just really back up what Steve's saying. It doesn't have to be the be all and end all of it to people, not at all. And I think the other thing I would also add, and no, we're not here to talk about PCRs, but people get so hung up on getting down 0.1 and lower. And minor changes beneath 0.1 is really background noise. It really is. And I think we do need to be aware of that, not to get too hung up on it is really what I'm saying there. And these numbers, as long as you're in 0.1 or there or thereabouts, you're in a very safe position. I'm not a doctor, but Steve, I'm sure you'd agree with that.
Yeah, I would.
Yeah, it's one of the things I often notice when people are talking about PCRs moving up and down at low levels. When you actually say, well, 0.01 to 0.013 is only 3 in 100,000 more cells. When you talk in real terms and absolute terms, people go, oh, that really isn't much. So a lot of that movement around is really minuscule.
Yeah, that's a good message, not to get hung up on these things. I think, yes, Steve, thank you for bringing that up, because that is one of the questions we had beforehand. Is someone asked, do I have to stop treatment? And it seems as if the resounding panel view is no, absolutely not. There, I guess that gives us a third option to talk about today, is stopping treatment, reducing dosage, or just carrying on as you are. Is a perfectly reasonable position to be in. Just going back to attempting TFR, if we may, we've talked about TFR at the moment as coming off treatment, as a concept, but we've had a few questions about specific treatment. So there are obviously a few TKIs available and a few more in the pipeline. Does it matter which treatment you're on, essentially, Steve?
So the reality is that the vast majority of people, and I think quite rightly, with CML who start treatment start on imatinib. Now, imatinib is the oldest treatment. It was first presented at a scientific meeting 22 years ago. I was there, and it makes me feel very old, in New Orleans. And then it got licensed and NICE approved maybe 20 years ago. So, it's been around for ages, actually, now, imatinib. And then all these newcomers came along, and the drug companies would have us believe they were much better, and we should all start using these first line rather than old-fashioned imatinib. And to cut a long story short, the new drugs have their place, of course, but broadly speaking, they're better for second line. And again, you'll get doctors disagreeing on this, so I'm just giving my view, take it or leave it. And the reason I'm not a big fan of starting second generation drugs like nilotinib and dasatinib for first line is because they have additional side effects. Nilotinib is a concern about cardiovascular risk, especially as you get older. Dasatinib I mentioned already, pleural effusion, and there's a couple of others as well. So imatinib is really the standard. So the vast majority, I'm just looking at my crib sheet here, of the 2,974 patients involved in 21 studies, just eyeballing my crib sheet here, I would say that 3/4 of those patients, so the majority, have been involved in stopping studies with imatinib. So let's do some broad figures. If you take people who've got a great molecular response on imatinib and stop 100 people, then approximately 50 people after a year or two will stay with no detectable disease. So a successful stop, roughly 50%. And the figures vary, of course, between different studies. Broadly speaking, and the numbers are smaller, if you look at people who stop from taking a second generation drug as first line treatment, then the success rate is a bit higher. It might be 55 or 60. But if you bear in mind that the proportion who could try stopping from a second generation, and I hope I'm not confusing here, is higher because the molecular response rates are higher, then overall, you've got probably more people who could try stopping from a second generation drug, and you've probably got a slightly higher success rate when you stop a second generation. But I'm a bit wary of that because the numbers are a lot smaller, and the vast majority of experiences with imatinib.
Great, thank you for explaining that. But I guess a similar related question is, does it matter what stage, I think someone brought this up earlier, does it matter what stage of diagnosis, let me put that differently. Once you get to the point of TFR being an option, is the stage at which you were diagnosed a factor in the decision making?
Mostly no is the answer, but I'd qualify that a little bit. Historically, and it's almost a thing that you just read in textbooks now and again, because fortunately we don't see it very often. But historically, there were different phases of CML, and we still call the earliest phase chronic phase CML. So that's where most people get diagnosed. I'm unfortunately old enough to remember in the 90s that without these treatments that we've now got, people, unfortunately, within 4 or 5 years would progress from chronic phase to a so-called accelerated phase, and then a thing called blast crisis, which sounds very dramatic, but a blast is a very early leukemia cell. So it was the emergence of a transformed and very aggressive form of leukemia. Fortunately, that is really rare these days. It does happen exceptionally, but it's really quite rare. If you present in blast crisis, and that's less than 5% of all people with CML, then and you get control of the disease with the TKI or whatever, I personally would be really quite wary about suggesting stopping to that person. I think they have more aggressive disease from the outset biologically. And most of the studies would have excluded those kind of patients from trials from a safety perspective. So I think that's uncharted territory, and I personally would be quite wary about that. The situation that David described, you know, very high levels of PCR positivity, maybe quite a few more blasts around, but not properly blast crisis. I think a lot of folk like David respond very well. And I think David's a great example of that. So, you know, a few higher blasts, a kind of high white count in itself, a higher PCR level at diagnosis. There's no great evidence that precludes you from trying to go for a TFR, or indeed makes the outcome worse. If you look at what's called a multivariate analysis, that's been encompassed. And the two things I mentioned at the beginning that really matter with regard to success are how long you've been on treatment, number one, the longer the better. How deep was the molecular response before you stopped, the deeper. Yep. So how you were at diagnosis shouldn't always affect or necessarily affect whether you can try stopping.
And David, I just wondered if you wanted to respond to what Steve said there. Is that something that you worry about, the fact that you didn't respond particularly well the first time?
No, in fact, I just thought of it as I was making the intro. As I was reading through my sheet history, I thought, oh, I wonder, does that make a difference to TFR or not?
Sorry.
Right. I guess, though, just another question as well. So we've got all these different prognostic scores. I think we've got Socal scores, ELTS. Do any of them correlate to success or not in TFR?
Two answers to that. One is, you know, I'm not a fan of scores generally. There's a whole industry in not just this disease, but many leukemias of coming up with scores, and some of them are good.
Sorry, Steve, can I interrupt a sec? Do you want to just tell people what Socal and scores are?
So sorry, I was presuming. Joe Socal was a hematologist from the US, probably in the 80s actually, who cooked up a score, which is, excuse me, was based on four things initially. It was bits of your blood count, how big your spleen was, how many blast cells you had, and that kind of thing. But basically, it told you how early or late you were picked up. So, you know, very simply, if you went in for a hip operation and had a blood count and your white cell count was 20, but nothing else, and you had CML, that's really early. If you presented to the doctor with, and this used to happen in the 50s and 60s, it's really rare these days, you know, but with a huge spleen the size of a rugby ball and anemia and feeling terrible, you had been presenting quite late. So the Socal score was the first of these things. that basically gave an idea of how long you'd had CML and how advanced it was when you were diagnosed. And then there was a gentleman, or there is a gentleman called Jörg Hasford, who's another statistician, German, who added 2 extra things to that. So there's 6 things in there. Now, I don't sit down at diagnosis. Don't tell my colleagues this, otherwise I'll be banished, but it's the truth. I don't sit down and work out every single person's Socal and Hasford score. Why don't I? Because I was involved in the imatinib studies at the very beginning and, you know, wrote the first big paper on it in 2003. And we looked at all that stuff. And it used to make a big difference in the 90s when you were on interferon and other things, but it doesn't make that much difference now. So if you have a high Socal score, that would reflect kind of what Charlotte's talking about, which is, you know, more advanced disease maybe when you were diagnosed, but actually you respond great still to treatment. And the progression rates, overall survival rates, etc., are not hugely different, not significantly different between the different scores. And also when, again, in multivariate analysis, you look at the factors that determine success when you come to stop, those scores don't matter very much. So I'm not a big score fan.
To add to that, Steve, my doctor did score me in all those when I was diagnosed. I was Socal high, Hasford intermediate, UTOS low, and ELTS high.
There you go.
Maybe that makes the point.
I think you've summarised why I'm not a fan.
Yeah.
And here you are, you're doing fine.
Yeah,
so
great.
What did the Socal high tell us about you?
I think it just told me I had a big spleen.
Which you probably already knew already. Oh dear. Thank you for that, Steve. I think that's helpful. I know you've sort of repeated a few times already that, you know, the length of time in remission, deep remission, molecular remission is probably the main thing that's important. But there is one question about multiple TKIs and whether, having had sequential TKIs, I think you kind of touched on this a little bit when we talked about imatinib versus dasatinib and things, but multiple TKIs, would that be something that would concern you in terms of starting or considering TFR? You are on mute. Okay.
Schoolboy error.
That's okay.
2 things come to mind there, really. The first is that, you know, the body of evidence to try and answer your question is lacking. As I mentioned before, the vast majority of stopping studies have taken patients who had first-line imatinib, hadn't switched or had any tricky course in their first few years. So very straightforward patients who just responded very well and then stopped. So if you had switched to nilotinib, for example, from imatinib, a lot of those original studies would have not allowed you to participate. So it's difficult to answer your question with good evidence. The second thing I'd say is if you have switched from imatinib to a second generation drug, and again, for people relatively new to this, there are 5 drugs in CML. There's one which is like the domestos drug, which I think we leave in the cupboard until we're really stuck. That's ponatinib, because it's very potent and very effective, but also probably has the highest side effects. There's 3 in the middle, which are, I tend to use for second line, which is nilotinib, dasatinib, and bosutinib. And then there's imatinib, which is the standard treatment. Now, if you'd started imatinib and you were not responding to the treatment, your white count was just not coming down, or your PCR was terrible, having had it for 6 or 12 months. So you changed to a second generation for reasons of resistance. I think that's different to if you change to a second generation for reasons of intolerance or side effects. I would be quite wary, and again, the evidence is a bit lacking, but I'd be much more cautious about stopping somebody who had had resistant disease to imatinib. It doesn't mean you can't try it, but I think much more circumspection is required. However, someone who'd switched to dasatinib from imatinib just because they couldn't tolerate imatinib and are doing great, I think you can be fairly relaxed about stopping there. So it depends on the reason that you're on a second line drug, really, Charlotte.
Great, thank you for that. There's one final question on this similar related topic, I guess, that I've just remembered. We've had a question prior to the webinar about people who may have stopped taking their TKIs for another reason. So we had one person say they stopped for surgery and another person say they stopped because they were pregnant and then quickly relapsed. And they're wondering if that therefore shows that they shouldn't try TFR in the future. Is that something that you'd agree with? Would you be wary of stopping those sorts of people who've stopped and not done very well on that temporary stop?
Yes, I would is the answer. I'm just looking at my crib sheet again because I checked this all out yesterday. So if you've tried stopping once, and I think Nigel had mentioned this at the beginning, so if you've tried stopping once and it didn't work, what evidence is there? What studies, what data are available to indicate whether stopping a second time is likely to work? Well, there are 8 studies available. So you remember I mentioned there were 21 of the original ones. There's only 8 with limited numbers of patients who've tried a second time to stop. And broadly speaking, and not surprisingly, the success rate is less than if you make a first attempt. So instead of being around about 50%, the studies vary, but they're kind of between 35 and 45. So let's say 40% success. And what's clear from those studies is if you had, when you stopped the first time, if your PCR shot up within 2 months, then the success rate in the second attempt is almost 0. Whereas if you were slow to relapse, and again, I'm wary about this word relapse. You know, in most settings, relapse of leukemia has a sort of terrible connotation that the world has all fallen in and I'm about to die. So maybe the word recurrence is better, or something a bit less emotive than relapse, because if you relapse and have a slightly higher PCR having stopped your treatment, it's nothing like having a relapse of acute myeloid leukemia, for example, which is really bad news. It's not really bad news if you stop treatment and then the PCR creeps back up. But if it creeps up early, the studies and the limited numbers, the studies are pretty clear that you have a small likelihood, if at all, of successfully stopping. Now, having said all that, I think, I wouldn't say I take that with a pinch of salt, but I don't think it's the whole story. And I think Nigel's situation, and it'd be interesting to see what he feels about this, is a good case in point. You know, if you've tried years ago and it didn't quite work for you, but you've now got under your belt another 5 years of super low level results, the studies that are around haven't looked at that really. So I still feel if you've got many years of low level disease, there's a reasonable chance that stopping a second time would be successful. And I don't think it's a no hope situation in terms of TFR. But again, the evidence base to inform that is pretty thin at the moment.
Yeah, my view on that, I stopped a little earlier than I probably should have. I was 3.5 years. Through my knowledge, through CML Horizons, which doesn't matter what that is, I think I stopped too early. At the time, I thought it was early. And to be honest with you, the main reason I did it is I think if you're going to talk the talk, you've got to walk the walk. And what I mean by that is, you know, I run a Facebook group. I sit here saying, oh, TFR, it's good, it's this, it's that, and the other, to then be in a situation where I'm offered it to turn around and say, no. So would I have actually done it at that moment in time? It is my choice. Probably. I knew at the time I was going to be a bit early. So my situation is maybe slightly different than a lot of other people who do relapse. I know that's a general wishy-washy answer. And I think it would be interesting to see how I get on with 5 years at deeper levels. I also stopped at a level of around MR4 because there was 2 groups. There was an MR4 and there was an MR4.5, which is almost undetectable. Therefore, by definition, my levels were higher anyway at the point of stopping. What's intriguing from what Steve just said a moment ago is the people who rise, because if you rise in month 1 or 2, you're almost certainly going to fail. So the question is, not particularly for an answer, it's a general question. Did I rise in months 1 or 2 because that's when I failed, or did I actually rise 6 months earlier because my levels started to creep up on half dose? Because certainly at the time when I started talking about half dose, because of the strength of imatinib, it's actually relatively rare for people to be much under 400 milligrams anyway. And it was certainly said to me at the time by a couple of doctors that by going to 200 milligrams, are you actually off treatment already? Which is maybe a slightly imponderable question. So therefore, did I actually fail at month 1? Or if you use that same theory, did I actually fail at month 7 or 8? There isn't an answer to that.
Yeah.
But that's why I'm willing to give it another go. I wouldn't do it if I didn't think I stood a chance.
Also, Nigel, presumably, if you had never tried stopping that previous time, you're now almost 10 years down the line, you'd be looking at yourself thinking you're in an excellent place to stop.
Yeah, I mean, if I hadn't have tried before, to be honest, I would have probably started about 3 years ago. But 3 years ago would have only been 2 years after I'd stopped, if that makes sense. It was too early. Just curious. Well, no, actually, I was going to say curious about the comment about the half dose, etc. But there are people under 400 mil who do okay on it. But predominantly, unlike the other TKIs with imatinib, most people are on full dose. Whereas David is a prime example, is on 1/5 dose. You can't really do that with imatinib.
Charlotte, can I just share one patient story with you, if I may? I've got a very feisty young lady that, well, I was going to say that I look after, but basically she tells me what she's going to do and I just have to write the prescriptions. It sounds like the women in my house as well. So, but she's lots of fun to talk to. But this young lady was diagnosed when she was about 30. And saw it as a major annoyance and inconvenience to her life and just wanted to get on with life, and told me in no uncertain terms that I just had to make the situation better so that she can get on with her family, which she was planning. So within 9 months of being diagnosed and starting treatment, she had an excellent molecular response, but decided that was the time she wanted to stop treatment, get pregnant, have a baby. And of course I advised that wouldn't be a great idea. She went ahead and did it anyway. PCR went up to, about 1%, something like 4 to 6 months into the pregnancy, and we hummed and hawed about what to do. And to cut a long story short, baby was fine, she was fine, restarted treatment. And then about 4 years in, she said, I'm going to have another baby, I'm going to stop now. And then went through the second pregnancy with very low, if any, detectable PCRs. Babies arrived, she could go back on treatment now. And we're now having a discussion to say, well, that didn't happen the same as the first time. 4 years on treatment. Now you've had best part of a year with no recurrence. Do you want to go back on treatment now, or do you want to just see how it goes? And she's going to see how it goes. So, N=1 experience there. But I think, as Nigel said, if you try stopping quite early and it doesn't work, I don't think that means you can never have another crack. It's just a matter. It's a marathon. This, you just have to put some miles under your belt and try again later. I
think patience is certainly something that's been a recurring theme so far, and also it's always good to hear a story of patients advocating for themselves and being a big part of their care. I think that's really important, especially when you've got a long-term illness like CML. You're in it for the long haul, like you say.
Charlotte, can I ask a question again for Steve to comment on? Because I did touch on it earlier, but I don't think it's actually been discussed. Can you give any idea to people watching, Steve, about the success rate of recommencing treatment? The other thing I'd also like to say, and I was part of the TFR group, a much wider group, an international one, and you touched on it a minute ago. You shouldn't think of TFR failure as failure, because bear in mind, you restart treatment at 0.1, and that's the goal that most people actually aim to get to. So you're actually starting treatment again at the point most people are actually aiming to get to. So it's not really failing treatment. It's just that TFR didn't work for you. So sorry, just the restarting thing.
Yeah, so I was just digging out. There's the most recent big paper on this was Lancet Oncology in 2018, and this is a follow-up of the EuroSki study. So in that study, there was just over 750 patients, 758. And broadly speaking, the success rate in that 750 at 2 years was about 50%, which is what I've said. And they confirmed this observation of longer duration of treatment and deeper response. But to come to Nigel's question, I've not got the paper right in front of me to specifically answer your question, but I can give you an idea. The answer is the vast majority. So of the 750, half of those had to try restarting to get back to control their disease. And I think from the abstract, which I looked at yesterday, and I can dig out again while we're talking, I think it was 1 or 2 people whose disease didn't respond after they restarted. So the vast majority of people have well-controlled disease once they restart. The things that people were worried about when these studies started off was, is anyone going to die of CML? If this goes really badly wrong, could you die? And again, in that biggest series from 2 years ago, 750 patients, there were a couple of patients died, but they died of other things. They didn't die from their CML going wrong. So I think the cumulative experience now of almost 3,000 patients in these various studies is really very reassuring. I don't think you, as Nigel quite rightly emphasizes, I don't think you need to feel that if you fail, and I don't really like the word fail, but if it doesn't quite work for you, stopping treatment, it's very unlikely you're going to come to any harm from trying. Your disease will still respond very well once you restart.
Great, thank you. And since we're on the topic, I wanted to ask David and Nigel's thoughts on what other risks you think there might be about TFR from a patient perspective. So Steve talked about a couple of clinical things and how if disease comes back, that's probably not a huge risk. But from your guys' perspective, are there any risks you're worried about with trying it?
From my point of view, if I choose to, no. I think we've got a very good testing facilities in this country. If I lived in maybe not such a developed country, I would have real worries about TFR. You see issues with somebody who comes off drug, their PCRIs, and they're not able to get back on drug because of restrictions in their country and availability, or that the PCR testing is poor quality and actually you can't accurately look at how you're doing. That's something we don't have to worry about in the UK, which is great. So in terms of the infrastructure and the expertise that would be around me, I wouldn't have any worries at all if I decided to do it, but not the same for everywhere.
How about you, Nigel? You said you were looking forward to 10 years having another go. How do you feel about it?
I have absolutely no concerns whatsoever about stopping treatment again, because I believe at the depth of response I have, it's safe. And I absolutely believe that recommencing treatment will work for me and for the vast majority of people. One thing we haven't touched on, though, with TFR, and I'm sure it's something we'll do in the last sort of 20-25 minutes, is the other aspects of it, be that withdrawal symptoms, be that the psychological crutch of losing treatment. I think there's a lot more to it rather than just shan't I stop treatment. I think that it does become a crutch to all of us, me as well. It's the what if and the worry about what if it doesn't work again for me. There is undoubtedly a withdrawal syndrome for some people. That is a factor as well. So, as I say, talking about it working is great, and it does work for, let's say, 50% of the people who get to a sufficient depth. And we have to stress that again. All the people watching here are thinking, oh, great, I'll be able to try it. A large proportion of people won't. You've got to get ultra deep for ultra long, not ultra, but for a good period of time. I think it's the other things is what I would push back with Charlotte.
Okay, thanks. Just picking up on the withdrawal symptom, that's actually going to be my next question. No, that's fine. It's great that people are anticipating my questions. Yes, Steve, well, what is this withdrawal symptoms that Nigel's alluded to there?
So this was a bit unexpected, and the story came out of Scandinavia. It feels like it was 5 years ago, but it's probably longer than that now, maybe 10 years ago. But, when these stopping studies first were there, nobody nobody thought there'd be any symptoms that might arise from it. So nobody really focused on that in the stopping studies. They were focused on the numbers and making sure people didn't relapse and all that kind of stuff. But then the Scandinavians said, you know, we're seeing people, when we stop this treatment, they get kind of aches and pains, and, you know, they're around the shoulder girdle and neck. They, you know, they're really, some of them really quite disabled with musculoskeletal pains. Has anyone else seen this? And then as people asked more, I just don't think people were asking in the original studies, but as people were asking more, then it came to light that, sure, this is actually a thing. And it's actually quite common. So it's probably less common, and it makes sense, I suppose. It's less common if you reduce and then stop, because you're kind of weaning off the medicine. But something like a quarter to a third of people who stop completely will get this so-called withdrawal syndrome. And it can be really pretty unpleasant for some people, you know, just feeling like lots of aches and pains. And the natural history of it is variable as well. So some people, it goes away after a few weeks or a few months. Some people, it doesn't go away. I've got one lady who was, it felt very odd at the time, but she was a successful stop, you know, 6 months in, 0% PCR, numbers brilliant. She wasn't brilliant, lots of aches and pains. And she said, can I go back on the treatment, please, doc? And I'm saying, well, you don't really need it for your leukemia. This is strange arthritis treatment I'd be giving you, i.e. imatinib. But these were early days. She went back on it. Her symptoms went away. So she is on imatinib to treat arthritis, if you like now, rather than to treat leukemia, if you see what I mean. But some people can't stop without having those kind of problems. It's a minority, but it's a real thing. And as I say, it seems to be less frequent and perhaps less severe if you reduce and then stop rather than just stop completely.
Is that the only option then if it's that severe, is to return to the treatment, or is there something else you can do, or is it just so early since this has been discovered that you're not quite sure yet?
It's been known about for quite a few years now, and I don't think there's a standard approach. I mean, broadly speaking, there's three things you can do. One is just tough it out, you know, see if it gets better with time, and that's, you know, easy for doctors to say and hard for patients to do. The second thing is go back on the TKI. But then, as I've mentioned, that feels a bit odd, especially if you had a brilliant response. You know, what's the whole purpose is to get off the TKI and see how you do. Why am I going back on it for these pains? But that's maybe something that has to be done. And the third is to treat it in its own right. You know, I'd be very loath to give steroids, for example. It would probably work, but you're just changing one toxicity and set of side effects for the toxicity from steroids. You can give arthritis type medicines, you know, non-steroidal anti-inflammatories, but they have their own side effects. So there's no standard way of managing it. And I think for some people, if they'd stopped at 400, and then when they restarted for this withdrawal syndrome, they were back on 200, you know, they've found a level that suits them. You know, it's enough to keep them out of trouble, but maybe not as much as they were on before. So no stock answer to that, I'm afraid, Charlotte, but it will often settle down with time, but not always.
I think the important thing is to mention it. If you're having these symptoms, is to say something, right? Yeah. And then obviously you as the doctors can then at least look at options if there are any, but always let your team know if you're experiencing these things.
Absolutely.
Okay, so we talked about risks. I wanted to go back to the positives a little bit, and maybe just go over what the benefits of TFR might be. I don't know whether, Nigel, you wanted to start from a patient perspective. You said you're coming up to 10 years and you're thinking about trying again. What is it that's driving you to try again, do you think? What are you seeing as the benefits after stopping?
From my personal point of view, other than the fact I'm likely to be on this drug for 40 to 45 years, that's it. I've said before, and I'm always very conscious of not rubbing people's noses in it. I am unusually rare that I have basically zero side effects. I work full time, I play squash, I live a normal life. You know, I often, you know, I could be swallowing a paracetamol for the impact it has on my body. Obviously, it has an impact on my CML, and I'm incredibly lucky. So for me, it is that reason and that reason alone. But I'm very unusual there, so I'm not the person to ask that question of, I'm afraid. I think
maybe that leads us nicely to David.
There are a lot of other reasons. There's a lot of other reasons that people would use other than mine.
Yeah, I mean, there's also kind of a psychological benefit, I guess, to it. That's what I've kind of considered. Then I kind of sort of have to challenge myself on it. Is that in itself worth it? But I guess it's not a case of that if I were to try TFR and I was successful, and I was successful for 5 years and we say functionally cured. It's not like I'm not going back to the hospital every 3 months or every 6 months for a PCR test. I'm still going to be a leukemia patient. I'm still going to the hospital. I'm still going to chat to my consultant. So it's not something I can just put behind me in my life. So does it really matter that I take a tiny 20 milligram pill every day? I mean, probably not, to be honest. That's where I'll probably end up. Because I'm not gonna be discharged no matter what.
Oh, that's an interesting perspective.
So David, can I just pick that up? I've thought of discharging 1 or 2 of my CML patients, but I've never had the courage. So there's a lovely lady that comes to see me who's now retired, but she was a primary school teacher when I first met her. She was the first UK patient on the old IRIS or 106 study in 2001. So she's now 20 years out. She's been PCR negative since about 2006. And every time she comes before Christmas and just wishes me happy Christmas, and it cheers me up no end. She didn't this year because we had to have a phone conversation because of the pesky virus. But every time she comes, I say, do you want to keep coming? Or, your PCR is negative. It has been for 12 years. Should we let you go from the clinic? And I think both her and I come to the same conclusion, which is we're not completely sure. So why don't you pop back and see me in a year? But what a delight that we can actually have that conversation, because, I grew up in an era where you wouldn't have dreamt of somebody with CML being potentially cured. But I think that lady's cured. And I'm very reluctant to use that word and hesitant because I'm quite a cautious doctor. But what a joy it is in this day and age with the benefit of modern technology that we can actually begin to have that conversation at all in this disease. So I think for those on the call, there's every room for optimism.
Absolutely. A really lovely story. I just wanted to pick up on David's points about monitoring that he's sort of mentioned a couple of times there. It kind of links to the story there. How long would you monitor people for? So you mentioned at the beginning, there are sort of protocols around initially it's 1 month a PCR test and then you go out to 3 months. But is there a point at which you'd ever let people go, do you think?
So the answer to that needs, as always, to try and be based on evidence. So I'm just looking at a paper here, which there's not many of these papers, but this is quite a good paper. It's from a very good chap in France called Philippe Rousselot. And he published a paper in Blood Advances last year, actually. And he was asking the question, how many people, if you've stopped treatment, how many people relapse late? Or is all the action over within 6 or 12 months? And the answer is, of all the people who relapsed, so let's get the numbers right. You stop 100 people, 50 people are going to not relapse. And I remember that I'm using the word relapse. Maybe it should be recurrence. Don't read too much into the word relapse. It's not bad news. 50 people will recur and 50 people won't. Now, of the 50 people who recur, when does that happen? The answer is the vast majority occur within 6 months. But what this French paper showed that of the 50 who recur, 14%, so that's 7% of the original 100, recurred after 2 years. So it can happen late, but it's unusual. And I think none of those, well, I don't think I know, none of those patients came to mischief. So what I tend to do, and it's broadly, I think, what most people do, and we haven't talked about COVID yet, but let's forget COVID for a second. But if it was easy and you come to the hospital and have a blood test, I would stop somebody tomorrow or reduce them, as we chose, and then I would ask them to do a monthly PCR. What I tend to do is give people 6 tubes and 6 postal boxes and say, can you sort this out yourself? Go to the GP, the practice nurse, whatever, and then send us the tubes, and then email me 2 weeks later or ring me and bug me to make sure we don't miss it. So, you know, it's not rocket science, but this needs quite a robust system. And I think if you're someone who's stopping, especially at COVID times when everything is stretched and, you know, you're on a phone follow-up and maybe you don't go to the clinic, make sure you bug your doctor 2 weeks after the blood sample to say, you know, what's my PCR doing? You haven't forgotten me, have you? But once a month for 6 months, then I'll probably do every 2 months until the year is up. And then I'd go back to 3 monthly. And there's some modeling, as I mentioned, it's not a completely reliable paper, but it's a modeled paper from Australia looking at when people are relapsed, how often you should sample and where that would fit. And I think by a year, most people would agree going back to 3 months is reliable and reasonable. But bear in mind that a small proportion of people will still have their PCR coming up even after 2 years.
Mm-hmm. And David, I wanted to come back to you and thinking about the story that Stephen was talking about there, where he was thinking about discharging someone, and you said to you, the important thing about TFR was knowing you were monitored. If you were Steve's patient, how would you feel at that point? Would you ever want to be discharged?
Maybe not, but what I probably would be happy is having blood taken, you know, maybe if I'm talking, let's say you're 15 years, you know, blood taken every 6 months or maybe every year later on down the line. And not having a clinic appointment, just getting a letter saying it's fine. That would probably be enough for me eventually.
Well, one thing I'd add here, and again, this goes back to the sort of the wider TFR group I was in, and it was one of my main concerns actually early on, is that we don't end up through goodwill and effort actually harming people who come off TFR, who are fine for a year, 2 years, 5 years. And I know late relapses are extremely, extremely rare. I'm talking 5-10 year late relapses. But there is always the danger that somebody did relapse 10 or 15 years on, and that they weren't having an annual, say even an annual PCR check instead of a 3 monthly, and that somebody then came back in blast crisis. And this is years and years ahead from now. And I do think to actually discharge someone, I'm sure it's why Steve doesn't do it, could be a dangerous thing, because TFR is ultimately still relatively new. Would I ever want to be discharged? No, I don't think I do. I think at minimum, say I was 10 years TFR, I think I would still want to have an annual PCR. And I do think that's important, because we're still in our infancies, and Steve smiles because you may or may not agree.
You know, well, I do agree, Nigel, and that's what I do. But it's because I'm a bit of a cowardy custard. You know, if we look at our patients who've had non-Hodgkin lymphoma or other forms of cancer, you know, if it hasn't come back in 5 years, and we absolutely do this with lymphoma, folk get discharged. You know, come back and see us if you have a problem in the future. Have a good life. Cheerio. I think that's a wonderful thing to feel, is, you know, the doctors don't want to see me anymore. I must be fine. But I don't do that for the reasons you allude to, Nigel. I mean, a PCR is easy, isn't it? It's not like a CT scan or a big faffy procedure. It's a piece of cake. And for the sake of it, doing it every 6 months, you know, it's a good thing. And at a selfish level, haematology can be pretty brutal sometimes, looking after people with very serious problems. So having people who are cured come back to the clinic raises our spirit. So that's a purely selfish thing, but I love seeing people come back who are very well, and or bring their babies to come and give me a hug as well. Mind you, we don't do that anymore, don't we? Shake hands, we don't hug babies. It's all gone. It's all telephone.
Well, while we're on the topic then, do you want to say if any of this is different with COVID? How has COVID changed your practice?
We haven't got time, and this webinar is not about COVID and the stuff that I know people discuss now and again. But in relation to TFR, I've had this conversation, I don't know, 5 or 10 times in the last 6 months, I think, which is, you know, you're right for trying this. You've had CML for 5-6 years. You've had brilliant results for 3 or 4 years. You know, this is something you could try. But my suggestion is, why don't we just get this virus out of the way and then try it? If someone's got side effects, I think that's a different conversation, because, you know, why wait if you're really being bothered with side effects? But if you just want to try because you'd like to be off for other reasons, mainly because of the faffing about with, well, there's two reasons. If you're going to have blood tests done once a month, you're going to have to go somewhere. And if you go somewhere, you're not in your home and you're not isolating and in lockdown. And we've all got to try that at the moment, as tiresome as it is. And the second thing is, I'm just worried the way that health services is obliged to work now, which is all on the telephone. People don't come to clinics as much. I just worry that someone who's on a monthly PCR might get missed off a phone list, or something might happen because we're not operating in a normal way, and therefore the rise in their PCR gets missed. So I think if you do choose to do it at the moment, then go for it, but really take ownership of what's going on. Make sure you bug your doctors or nurse specialist 2 weeks after you've had the test, say, what did the last one show? What's the last one? And just obviously, if you're going to have blood tests, be super careful, mask, visor, in and out as quick as possible. So I wouldn't say no way, don't do it. But if you're not in a pressing hurry, then maybe when virus is better would be good.
A bit of background noise there. Yeah, Nigel, that's something you alluded to at the beginning. Do you agree with Steve's thoughts on whether, say, COVID is still around in September, when you were thinking, oh, it would be nice to try? Would you change your mind, do you think, or delay a little bit?
I'm quite optimistic that by September we'll be in a fairly different world.
I am too.
So, and you know, to be honest, yeah, okay, it's 10 years in September. Does it actually matter if it's 10 years and 3 months or 10 years and 6 months? Of course it doesn't. So, you know, if September became January or became March of next year, I don't really care. I don't mean that flippantly. But you wouldn't want to be going up and down the hospital at the moment. It's not the right thing to do.
Yeah, I agree, definitely. Okay, so we're coming towards the end of our allotted time. I just wanted to say to everyone, I've seen a few questions that are quite specific to people's situations. That's not really the sort of thing we're able to answer today. If you've got a sort of specific question about your own situation, your levels or your PCR results, that sort of thing, please do go speak to your haematology team, and they'll be better placed to answer those questions. I think we've covered most of the variety of questions. Thank you all for being so active in the chat. We're doing our best to cover them all.
Carla, can I just get in?
Of course.
I've sent you, as a little message just now, a web link to a publication. It's not behind a firewall. I mean, the full paper is. But if you want to disseminate that to everyone on the call just now, it's public domain. And it's a very recent article from December about discontinuation of TKIs, when and for whom it's called. So I think a lot of people might find that useful, and it covers a lot of the things that we've been talking about. It's up to date. It has references to all the papers for people who'd like to go and actually find more detail. So feel free to distribute that on the call just now or afterwards as you wish.
Perfect, thank you, Steve. Just while we're on the topic of evidence, I did want to ask you one very quick last question, if I may. The future and future research in this area, where do you see that going? What questions remain to be answered in terms of trials and scientific work?
Yeah, the honest answer is I'm not sure there's going to be much more, for a couple of reasons, really. One is I think it's really hard to get funding to do this. A couple of reasons, really. The drug companies don't want to fund this, because why would they? Because we're getting people to stop potentially expensive treatment, so they're not going to do that. The cost savings that would have accrued from imatinib when it was £20,000 a year have diminished greatly, because it's now generic and it's a few £100 a year. So the public sector, the health service, isn't that interested in doing it. So from a logistics point of view and a funding pragmatic point of view, it's quite difficult to get these sorts of studies done. And secondly, I think we probably know 90% of what we need to know. You know, we know it's pretty safe. There's a debate about whether reduce and stop is better than stop, but we have a pretty good idea of, you know, go on for a few years before you try. reduce if you wish or stop if you wish. We know about the withdrawal syndrome. We know that people respond when they go back on, so risks are small. So I wouldn't say there's nothing more we can learn, because there's never nothing more that we can learn. But I won't foresee that we're going to have in the next 5 years loads more scientific studies that will change most of what we've been discussing today. I think the research has largely been done.
Mm. Okay.
One question, sorry, Steve. Budgets for drugs against PCR tests, do they come from different budgets, and does that affect a hospital? I know it wouldn't, probably a clinician. Would that have any impact on things? Because as you rightly say, you know, months imatinib 20 quid, PCR test £200.
I think if you put it in a formal business case and submit it to your medical director, again, don't snitch on me, guys. Someone's going to look at the numbers and say, hang on, this used to make sense, but it doesn't anymore. But actually, I think you can sneak it through. So
it's not going to, shouldn't be a problem with the hospital, is the
I don't think so.
question.
So the basic answer to your question is yes, it is different budgets.
Yeah.
You know, the laboratory testing and the drug budget are different things.
Mm.
But because this is not a lot of patients, because in the end you're going to save money, and especially if you're stopping nilotinib, you're going to save money instantly because it's not yet off patent, although it will be in a few years. In my hospital, and I think in most places that I've spoken with colleagues about and patients, I've not heard it being a problem. It's a theoretical one, Nigel, and it's, if someone was being super stingy, they might pick up on it, but realistically, it doesn't get picked up on, and you should be fine.
Okay, thanks.
Great, thank you. Great question,
And
Nigel.
I just want to really emphasize the point that David made before. Sorry, Charlotte.
No, that's fine.
You know, there used to be a bit, well, there used to be a real worry actually about access to medicines in CML. And, you know, because we have a fantastic health service, and I'm not going to advertise for NICE, but you may or may not like NICE, but I think that process of rigorous examination of effectiveness and cost effectiveness, it means that we have an amazing access to the most effective and beneficial drugs in the NHS. So if you are worried that if you were to stop a drug, someone might say to you, oh, sorry, you can't have that one again. That's been raised, it's been covered, and it's not a problem. You can go back on the treatment you were on if you have a period off it trying to achieve TFR.
Thank you for clearing that up. That's a really interesting place for us to end there. Thank you to our panel. It's been a great discussion. I think we've covered a crazy amount of information in a very short space of time. We could have talked about this all night, but we've all got dinner to eat and relaxing to do, even if we can't go anywhere. So thank you for your time. I just wanted to end with a bit of extra information. We will disseminate the link that Steve shared with us if anybody did want to read up any more. But just to mention that we have our specific booklet about TKIs and TFR if you are about to start or interested in the process and wanted to read up a little bit more. There's our booklet there, and obviously the slide shows a variety of other information sources we have. Next slide, please. I just wanted to pop in there an advert for our next webinar, which is on the 4th of February. We'll be covering COVID-19 with a focus on coping and support if you are shielding currently or otherwise feeling isolated. So please do sign up for that one if you've got any questions. We'll be joined by a couple of psychologists for that one. Yeah, so if you're in need of support, please do join us. While we're talking about support, a whole array of other support mechanisms that you can access from us. Just a word for Nigel's Facebook group, Nigel and David's Facebook group here. They've been fantastic in helping us recruit patients for this webinar. I hope the group have found it useful. Please do join that group if you haven't already. It's a wonderful community of patients looking after each other. Next slide, please. Just a word for there are other sources of support out there, CML support, Blood Cancer UK, that you can access if you prefer. And I think, yeah, wonderful. Last slide. If you do want any more information about any of the topics we've discussed today, support on any other aspect of being diagnosed with CLL or living with CML, apologies, please do get in touch with us. That's our helpline number, open sort of 9 to 5-ish, Monday to Friday, or drop us an email. Thank you. Thanks again to our panelists. Thank you for all the kind
Thanks
comments
all.
in the chat box. I'm glad you all found it useful, and have a lovely evening, everybody.
Cheerio.
Thanks.
Bye all. Thanks.
Bye everyone.